Every morning, millions of people over 60 wake up with the same ritual. They reach for a pill bottle before their feet hit the floor. Burning in the feet, shooting pain down the leg, that deep, persistent electric ache that no comfortable position can quiet. You have tried resting it, you have tried moving more, you have tried ignoring it, which worked for about 4 minutes. And when you finally sat across from a doctor, you walked out with a prescription Gabapentin or Pregabalin and a brief explanation that amounted to, it calms the nerve signals. That answer is incomplete. And in most cases, it leaves out the part that actually matters. These medications do not treat your nerve damage. They reduce the volume on the signal your brain receives. That is a meaningful distinction because it means the damage continues while the alarm goes quiet. And that means your approach to this condition needs to be considerably more than a pill taken twice daily. What you are about to hear changes how you think about nerve pain and about what is genuinely available to you. Subscribe and hit like right now. This channel is building toward a community of people who are done being managed and ready to be informed. Every subscriber makes that possible. Here is something worth knowing before we go any further. The healthcare system is not built to keep you well. It is built to keep you coming back. There is no billing code for a 40-minute conversation about the physiological difference between masking a nerve signal and repairing the nerve itself. What you are about to hear, nobody at your next appointment is going to volunteer. So subscribe, hit like, and let's get into it. Let us start with exactly what is happening inside your nervous system when nerve pain develops, because understanding the mechanism is the only reason any of what follows will make sense. Your peripheral nervous system is a vast network of nerve fibers running from your spinal cord outward to every region of your body, your feet, your legs, your hands, your skin. These fibers are not raw wires. Each one is wrapped in a protective sheath called the myelin sheath. Think of it as the insulation around an electrical cable. That myelin sheath allows signals to travel quickly, cleanly, and accurately from the periphery back to the brain. Now, in healthy nerve tissue, pain signals follow a specific and purposeful pathway. Damage occurs, you step on something sharp, you compress a joint, and the nerve fiber at that location fires a signal that travels up through the spinal cord and registers in the brain as pain. The signal is appropriate. It is telling you something real. Here's what changes in neuropathy: damaged nerve conditions under the influence of prolonged inflammation, metabolic disruption, or physical compression. The nerve fibers begin behaving erratically. The insulating myelin sheath thins or breaks down, and when it does, the nerve does not go quiet. It does the opposite. Damaged, demyelinated nerve fibers, fibers that have lost their insulating coating, develop what researchers call ectopic discharge. Ectopic means originating in the wrong place. These fibers begin firing spontaneously without any external trigger, generating pain signals from nowhere. Your brain receives a pain message, but there is nothing actually injuring the tissue at that moment. The alarm is going off in an empty building. This is the mechanism behind the burning, the tingling, the shooting sensations, and the painful sensitivity to even light touch that characterizes peripheral neuropathy. Now, where do gabapentin and pregabalin fit into this picture? Both medications belong to a class originally developed for epilepsy, anticonvulsants, drugs designed to reduce abnormal electrical firing in brain tissue. Researchers discovered that the same mechanism that quiets overactive neurons in seizures also quiets overactive peripheral nerve fibers in neuropathic pain. Specifically, these medications bind to a particular protein on nerve cell membranes, the alpha-2 delta subunit of voltage-gated calcium channels. That is a technical name for a very specific gate. When this gate is partially blocked, the nerve releases fewer neurotransmitters, fewer chemical messengers that carry the pain signal forward. The nerve is still damaged. It is still misfiring, but the signal reaching the brain is significantly reduced in intensity. Think of it as turning down the volume on a fire alarm. The fire is still happening. The alarm is simply less deafening. This distinction matters enormously, and this is where most patients are not getting the full picture. These medications manage the symptom. They do not address the nerve damage driving it. And that means the work of actually recovering nerve function, or at minimum stopping the progression, requires an entirely different set of interventions. That is what the rest of today is about. Clinical research validates that gabapentin and pregabalin provide meaningful symptom relief in two specific conditions: sciatica caused by lumbar nerve root compression and diabetic peripheral neuropathy. For other forms of nerve pain, phantom limb pain, chemotherapy-induced neuropathy, certain idiopathic forms, the evidence for these medications is considerably weaker and more variable. That variability matters to you personally, because if you have been on one of these medications for months and your relief has been partial or inconsistent, that is not a dosage problem. That may be a problem of mechanism mismatch, a drug designed for one physiological pathway being applied to a different one. Now let us get into the specific mechanisms driving nerve damage. And I want to start somewhere that will genuinely surprise most people, the gut. I know what you are thinking. What does the gut have to do with nerve pain? I am going to explain that connection precisely, and I think you will find it changes how you understand everything. The first factor is vitamin B12 deficiency. And the reason I begin here is that this is the single most underdiagnosed reversible driver of peripheral neuropathy in adults over 60. Vitamin B12 is not optional for nerve function. It is structural. B12 is required to maintain the myelin sheath, the insulating coating I described earlier. Without adequate B12, the body cannot produce or maintain myelin properly. The sheath thins, nerve conduction slows, and the misfiring, the ectopic discharge begins. Here is what makes this particularly important for older adults. B12. Absorption requires a protein produced in the stomach lining called intrinsic factor. As stomach acid naturally declines with age, a process called hypochlorhydria, the production of intrinsic factor decreases as well. This means that even if you are consuming B12 through food or standard supplements, your gut may not be absorbing it effectively. The figures here are clinically documented and sobering. Research published in the American Journal of Clinical Nutrition found that approximately 40% of adults over 60 have low or borderline low B12 levels, many without any awareness of it. For those taking metformin for type 2 diabetes, the rate of B12 depletion is even higher because metformin directly impairs B12 absorption in the small intestine. I am not saying this to alarm you. I am saying it because this is correctable. And correcting a genuine B12 deficiency often produces meaningful improvement in neuropathy symptoms, sometimes comparable to what medication achieves without the side effect profile of a pharmaceutical. The most absorbable form for older adults is methylcobalamin, not the cheaper cyanocobalamin found in most generic supplements. Ideally taken as a sublingual tablet, one that dissolves under the tongue because sublingual absorption bypasses the digestive absorption issues entirely. The second factor is one that almost no one in a clinical appointment will discuss in this context, and that is blood sugar dysregulation. Not only in diagnosed diabetics, but in the significantly larger population living with insulin resistance and prediabetes, who have not yet been formally diagnosed. Here is the mechanism. Chronically elevated blood glucose damages nerve fibers through two distinct pathways. The first is direct glycation, glucose molecules attached to proteins within the nerve fiber wall, stiffening and degrading the structure. The second pathway is oxidative stress. High blood sugar generates an excess of free radicals, unstable molecules that damage cell membranes. Nerve cells, which require enormous amounts of energy to function, are particularly vulnerable to this oxidative damage. The physiological result is a condition called distal symmetric polyneuropathy, damage that begins in the longest nerves first, which is why diabetic nerve pain almost always starts in the feet before moving upward. This is not coincidence. It reflects the mechanism. Clinical research published in peer-reviewed literature consistently shows that well-controlled blood glucose not only slows the progression of diabetic neuropathy, it allows existing nerve fibers to begin recovering. Nerves can repair themselves. They do so slowly at a rate of approximately 1 millimeter per day, but recovery is genuinely possible when the damaging stimulus is removed or reduced. If your neuropathy has a glycemic component and that blood sugar is not being actively managed, then every other intervention, including your medication, is fighting against a current that is not slowing down. The third mechanism involves something that almost nobody in this context discusses: chronic inflammation driven by the gut microbiome. I want to be precise about this because it is an area where the science is solid, but the clinical translation has been slow. The nerve fibers of the peripheral nervous system do not exist in isolation. They are bathed in the same systemic inflammatory environment that your immune system creates. And the single most powerful driver of chronic systemic inflammation in the modern human body is intestinal dysbiosis, an imbalance in the bacterial communities of the gut. When the gut microbiome is disrupted by antibiotics, by a diet high in processed foods, by chronic stress, it produces increased intestinal permeability, commonly called leaky gut. In this state, fragments of bacterial cell walls, specifically a compound called lipopolysaccharide, pass through the gut lining into the bloodstream. The immune system treats these fragments as an invasion and responds with a persistent, low-grade inflammatory cascade. Research published in peer-reviewed pain journals has documented elevated inflammatory markers, specifically interleukin-6 and tumor necrosis factor alpha, in patients with peripheral neuropathy compared to controls. These are the same inflammatory mediators that directly sensitize peripheral nerve fibers, lowering their firing threshold. This means your nerves are set to alarm at a lower stimulus. The signal does not need to be as strong. Pain is amplified. Here is the genuinely good news. The gut responds to change. A shift toward fermented foods, reduced ultra-processed food consumption, and targeted probiotic support measurably reduces circulating inflammatory markers. Research consistently demonstrates this effect within weeks of dietary change, not months. The fourth factor is one that the vast majority of patients never hear connected to nerve pain, and that is vitamin B1, specifically in the form called benfotiamine. Thiamine, which is vitamin B1, is essential for the energy metabolism of nerve cells. Every peripheral nerve fiber in your body runs on glucose. To convert that glucose into cellular energy, it requires a series of enzymatic reactions, all of which depend on thiamine as a cofactor. When thiamine is deficient, nerve fibers cannot generate adequate energy. Their function degrades, conduction slows, pain signaling becomes dysregulated. Benfotiamine is a fat-soluble form of thiamine that crosses into nerve tissue far more effectively than standard water-soluble B1. Multiple clinical trials, including studies published in the European Journal of Clinical Investigation, have demonstrated significant reductions in neuropathy symptoms with consistent benfotiamine supplementation, particularly in patients with diabetic neuropathy. In one controlled trial, participants experienced meaningful reductions in burning and tingling symptoms compared to placebo after 3 weeks of supplementation. Before beginning any B1 supplementation, I would strongly recommend having your B12 and B1 levels tested. Correcting a genuine deficiency is the most direct path to meaningful improvement, and it does not appear on your pharmacy receipt. What follows is a 4-part daily protocol built around the 4 mechanisms we just covered. I am calling it the Nerve Recovery Foundation Protocol, not because it promises recovery in a fixed number of days, but because it builds the physiological foundation that makes nerve recovery possible. Without this foundation, symptom management is all you will get. With it, you are working at the level of the problem. Part 1, nutritional repair. Every morning, your first action is to support the 2 nutrients most critical to nerve structure. If your B12 levels have been confirmed low, methylcobalamin sublingual, under the tongue, not swallowed, at 1,000 micrograms per day. If your levels are borderline, work with your physician on appropriate dosing. Separately, benfotiamine, the fat-soluble B1 form, at 150 to 300 milligrams daily with food. This is not optional for anyone with blood sugar dysregulation. It is structural. If you are taking metformin, have your B12 tested every 12 months without exception. Metformin consistently and measurably depletes B12 over time. This is documented in the product prescribing information and widely acknowledged in endocrinology literature. It is frequently not mentioned at the time of prescription. Part 2, blood sugar stabilization. This is the most powerful single intervention for anyone with diabetic or pre-diabetic neuropathy, and it is available to you right now, today, regardless of whether your physician has formally addressed it. 3 specific actions. First, eliminate liquid sugar entirely. Fruit juice, sweetened beverages, and glucose-spiking drinks produce the sharpest post-meal blood sugar elevations with no compensating fiber to slow absorption. Second, add a short walk, 10 to 15 minutes after your largest meal of the day. Research published in Diabetes Care demonstrates that post-meal walking reduces the postprandial glucose spike, the sharp blood sugar rise that follows eating, by approximately 22% compared to remaining seated. That specific timing matters. Post-meal, not pre-meal. Third, add 1 to 2 tablespoons of apple cider vinegar, diluted in a full glass of water, before your largest meal. Multiple small controlled trials have documented reductions in post-meal blood glucose with consistent pre-meal vinegar consumption. The mechanism is inhibition of certain digestive enzymes that break down starch into glucose. This does not replace medication, it works alongside it. Part 3, gut microbiome support. Beginning this week, add 1 serving of a live culture fermented food daily. Plain yogurt with active cultures, kefir, or traditionally fermented vegetables such as kimchi or sauerkraut. The goal is consistent daily exposure, not a megadose once a week. The microbiome responds to regular input. Simultaneously, reduce 1 specific dietary category that directly destabilizes the microbiome and fuels intestinal inflammation. Emulsifiers found in ultra-processed foods, carboxylated hydroxymethylcellulose and polysorbate 80, ingredients listed on packaged foods have been shown in laboratory and clinical research to disrupt gut barrier integrity. The practical action is straightforward. Reduce packaged food consumption and replace one ultra-processed item per day with a whole food alternative. That is a sustainable, non-expensive change that begins repairing the inflammatory environment within which your nerves are functioning. Part 4. Topical symptom management. This will not treat the underlying damage, but it meaningfully reduces the day-to-day symptom burden, particularly during flare-ups, without adding to your systemic medication load. Capsaicin cream at 0.025% to 0.075% concentration applied to the area of pain 2 to 3 times daily. Capsaicin works by depleting substance P, a neuropeptide that carries pain signals from peripheral nerve endings to the brain. With repeated application, the nerve endings are progressively desensitized. The critical information that most people miss: for the first 3 to 5 days of use, capsaicin may temporarily increase the burning sensation as substance P is depleted. Most people stop at this point. That is the most common error. By days 7 to 10 of consistent application, the majority of patients experience meaningful reduction in symptom intensity. Consistency is the entire mechanism. For anyone with open skin, active rash, or known capsaicin sensitivity, use Arnica montana extract topically instead. Well-documented anti-inflammatory properties, no sensitization risk, applied directly to the area of discomfort. These 4 parts work as a system, not as a replacement for your medication. That is a conversation you have with your physician as the biological foundation that makes either medication or natural recovery possible. Within 4 to 6 weeks of consistent adherence, you will see measurable changes, not because of any single ingredient, because you have addressed 4 of the underlying mechanisms simultaneously. That is physiology, not magic. Here is the week-by-week plan. Week 1, foundation. Get your B12 level tested. Begin methylcobalamin sublingual if deficient. Begin benfotiamine if you have any blood sugar history. Begin post-meal walking 10 minutes after dinner every evening. Just these 3. Consistently, internally, the process has already started. Week 2, activation. Add daily live culture fermented food. Begin reducing one ultra-processed item per day. Add diluted apple cider vinegar before your largest meal. Begin capsaicin cream application and commit through the initial days of increased sensation, days 3 to 5. The mechanism is working. Week 3, observation. Is the burning at night less intense? Is the tingling starting later in the day? Is the frequency of shooting episodes reducing? These are the first signs the inflammatory environment is shifting. Subtle in week 3, clearer in week 4, week 4 and beyond. Consolidation. You are no longer masking a symptom. You are changing the environment generating it. Not only reduced pain, but often improved sleep, more stable energy, and measurable post-meal glucose improvement. Because you have not been treating the nerve in isolation, you have been treating the entire system it lives in. Here's something worth noting before we move to the final section. The risk profile of gabapentin and pregabalin changes significantly with age. After 60, kidney clearance, the rate at which the kidneys filter these medications from the bloodstream, declines measurably. This means standard doses can accumulate to higher effective concentrations than intended, amplifying both therapeutic effects and side effects. After 70, the fall risk associated with dizziness and drowsiness from these medications becomes a clinically significant concern. Falls remain among the leading causes of hospitalization in that age group. How old are you? Write it in the comments right now. I want to understand the age profile of this audience so the content I build from here is calibrated precisely to your risk profile and your physiology. That number genuinely affects the recommendations I prioritize next. Here is the complete picture. 4 mechanisms drive peripheral neuropathy and amplify its symptoms. Myelin breakdown from B vitamin deficiency, oxidative nerve damage from blood sugar dysregulation, systemic inflammation from gut microbiome disruption, and ectopic nerve firing amplified by inadequate nutritional support. You now have concrete tools for each. B12 deficiency, methylcobalamin sublingual, levels tested first. Thiamine deficiency, benfotiamine 150 to 300 milligrams daily with food. Blood sugar dysregulation, post-meal walking, pre-meal apple cider vinegar, liquid sugar eliminated, gut inflammation, daily live culture fermented food, reduced ultra-processed food consumption, day-to-day symptom burden, capsaicin cream, consistently for 7 to 10 days minimum. Gabapentin and pregabalin reduce the volume on the pain signal. They do not stop the process generating it. Medication and the foundation protocol are not in opposition. They work best together while you build the conditions your nerves need to recover. The goal is always the lowest effective medication dose for the shortest necessary period, while your body does the deeper work. These tools cost very little. The physiological logic behind them is documented and sound. What was missing was the complete explanation. That is is what today was for. One clinical note before we close: never stop gabapentin or pregabalin abruptly. Both require a gradual taper under medical supervision. Sudden discontinuation can trigger withdrawal symptoms, anxiety, insomnia, and in some cases, seizures. Any dosage change needs to happen with your prescribing physician. If you are experiencing progressive weakness in your legs, loss of bladder or bowel control, or rapid deterioration of symptoms, those are reasons for urgent medical evaluation, not home management. If you are taking any opioid medication alongside either of these drugs, ensure every doctor in your care team knows about both. The combination significantly increases respiratory depression risk. Everything discussed today supports your body's own function. It does not replace clinical evaluation when something needs to be examined. Nobody in a white coat is going to walk you through this at a standard appointment. There is no billing code for the conversation we just had. There is no financial incentive in a patient who improves their B12, manages their blood sugar, and reduces their medication need over time. That is a fact of the system, not a criticism of the individuals working inside it. The system is structured the way it is. What you do inside that structure is your decision. I have spent many years in practice watching what happens when people are given a prescription without a mechanism and a side effect list without a context, and watching what changes when they finally get the full picture. If this gave you something you did not have before, subscribe and hit like, and share it with someone managing nerve pain. Your health is not a profit center here. It is the whole point.